Okay, so I'll try to get through some of these. I'm kind of lump some of them together because some of them are very similar. One is, should you push patient to exercise when they complain that they can't do it today? Well, that's a really good question. Parkinson's has, as part of its symptomatology, things like fatigue and lack of energy, and also sometimes the loss of motivation. So sometimes it's hard to get people to exercise, but to the extent possible, you should exercise every day. But the problem I see with this question is that this means that some caregiver is probably having to supply all the motivation to make the person exercise, and that's just exhausting for a caregiver, and most people can't be doing that. So what you need to do is figure out a way that the exercise can happen without the caregiver supplying all the energy behind it, because you'll wear out your caregiver, and that's a really bad situation to be in. So maybe a trainer could come over 3 days a week, or a neighbor could come over to walk with you, or you know, you could be in an exercise class. There has to be some other way to get exercise without it wearing out the caregiver. And there are some days that a Parkinson's patient just can't do it. But for the most part, everybody should exercise to some extent every day. Sometimes it's just a matter of figuring out when the best time is in terms of your medication. You don't want to go out for a walk when your medicine's just worn off. You want to find what's your average best time every day. That's the best time to be exercising. Can levodopa cause stomach pain? Well, it certainly can cause nausea and change bowel function to some extent, because most people with Parkinson's have constipation. So it's possible, but stomach pain is kind of unusual. So if that's a persistent thing, I would probably see your primary care doctor to make sure there's not something else going on, because sometimes I hear, oh, it's causing stomach pain, it's causing stomach pain, and it turns out the person has like an infected gastric ulcer or something like that. So when there's something like that that's not easily explained with the Parkinson's, go see your primary care doctor to make sure it's not something else. Is there maximum dosage of carbidopa, levodopa? The maximum dosage is the one that causes side effects in an individual patient. Again, we're trying to replace something that's made by the brain, that the brain needs to function. So I've got patients that are taking 2,000 or more milligrams a day of levodopa because they tolerate it. But you know, if everybody has a side effect ceiling, and at some point they're going to start having side effects. Until they get to that ceiling, there's not a maximum dose. Okay. Sometimes feel very tired during the hours after my midday dose. Again, fatigue is very, very common. I don't know exactly what the explanation is for this particular person, but you know, it is a drug. Sometimes drugs can make people feel sluggish. Maybe the dose needs to be adjusted. Maybe the person's not getting good sleep at night. Maybe they're taking other medications that could be making them sleepy. A lot of different possible explanations for this. Effect of Valium and Ativan on Parkinson's and Cinemet. There's no specific interaction. However, I like to avoid, these are benzodiazepines, Ativan and Valium. And benzodiazepines, if you look at lists of studies that have been done of falling in older people or in nursing homes or hospitals, the top 2 drugs on the list are always sleeping pills and benzodiazepines as causes for falling. People tend to get wobbly or confused or sluggish or groggy, and they tend to fall down with these drugs. So I prefer to avoid them. You can't always avoid them, but I prefer to avoid benzodiazepines. Safe maximum dose of levodopa, again, the one that doesn't cause side effects. When first taking carbidopa, levodopa, what strength should you take? Again, I can't answer individual questions about medications in an individual person. Generally, we start out with 25/100, half tablet 3 times a day at meals, and then go up to 1 tablet after a week for most people. Some people need more in the beginning. Some people can't tolerate this much because there's not enough carbidopa, and we need to load them up with pure carbidopa so that they don't have the nausea. Everybody's different, so you have to talk to your doctor about that. Somebody's taking Cinemet Comten 4 times a day and is having balance and freezing problems. Again, there could be something else going on here. Maybe they need more medication. Maybe the medicine's not helping. They probably definitely need physical therapy to help with that. A lot of other things could be going on here. How much does a positive attitude help in the symptoms and general health? Huge. Mental attitude is huge, and I see it every day. I have People come in with just a little bit of tremor and, oh, woe is me, this is so terrible. And I have people come in that are really, really affected and can barely walk. And I have one guy like that, I remember. He was so stooped over that he basically his face was parallel with the floor, and he was using a walker. And this guy never complained. And he and his wife, with whom he was madly in love after like 50 years, went on a trip to China with this group. And he did every single thing the group did, meaning going around on the cobblestones with his walker, did everything except climb the Great Wall of China. He went up in a gondola. That was the only, and he had a great time, no complaints. And then I get other people, you know, every little ache and pain is, you know, you'd think they were the only person that ever had one. So mental attitude is huge. It's a lot easier if you have a good one. There are some questions about Select. When is it going to be a generic? Not for a good long time. The last I heard it was like about 7 years, I think. So it's going to be a long time before Select is a generic. Issues with Select and Sudafed? Not really. You can take that, you know, let your doctor know that you're taking it. Don't buy too much Sudafed or they'll think you've got a meth lab at home. They won't let you anyway. But yeah, Sudafed, you might have to be careful for other reasons because it can keep you awake at night and things like that, but it's okay to take with Select. It's on that good list of drugs I told you about. Other Select things, Wellbutrin and Select, I think they took the Wellbutrin down to a warning from a contraindication, but you can talk to your doctor about that. The only one I think that they still don't want you to take is Prozac, because Prozac is a longer lasting SSRI, and they're worried about that, but I've had patients on that too, and I haven't seen a problem. Are there generics for the commonly available prescribed drugs? Just about everything now. The only thing there aren't generics for are Select and Comtan and Stalevo. Mirapex ER is coming out, I think, within the next year as a generic. Short-acting Mirapex or pramipexole is available. Requip XL just came out as a generic in the last month or so. So almost everything is available now as a generic. Even Lexapro, my favorite antidepressant, is escitalopram, and that's now available as a generic. The thing you have to watch for with generics is they don't always work quite as well as the original. So like for Lexapro, I've had a few of my patients say they're more depressed since they switched to the generic, so I may end up having to give them a higher dose of the generic than they had before. I don't know if you know this, but with generics, the way they get it on the market is they have to show that the average blood level of a group of people on the generic is within a certain range of the average blood level of a group of people on the brand name drug. And that range is 25% higher or 20% lower. So it's a lot of wiggle room. So you may not necessarily respond to a generic as much as well, or maybe you may do better on the generic because of that big range. So you have to be aware of that. So when you get switched from a brand name to a generic, or even from one generic to another, notice if it makes you feel different. And if it does, notify your doctor, because you may need a different dose. You may need a little more. You may need to say, well, this generic works, but that one doesn't. So the doctor can write, you know, for you to only get so-and-so's generic. It doesn't always work, but we can write it. And then just be aware, because these drugs are not exactly the same. The molecule of the drug is the same, but everything else, the filler, et cetera, the availability, may not be the same. How does sugar, high fructose, everybody knows high fructose corn syrup is the root of all evil. We don't really know. I haven't heard specifically, and nobody's done any studies of high fructose corn syrup with Parkinson's. It's clearly the case that if you, especially if you're diabetic and your blood sugar gets low or really, really high, that can make your Parkinson's act up, because anything can make your Parkinson's act up, any perturbation in the system. We already talked about stress and sleep, depression, surgery, anesthesia, what else? Bladder infection, pneumonia, new other medication, over-the-counters. Is there one I haven't thought of? Pain, misery, whatever. Happiness, too much excitement. Good stress can make your Parkinson's symptoms more pronounced. All kinds, anything that perturbs the system. So think of yourself as trying to maintain yourself in good health and good balance with good blood sugars, and don't do things you know are stupid, like drink too much alcohol, get dehydrated. Dehydration is another huge one with this hot weather. Dehydration can make your Parkinson's just go to, as they say, hell in a handbasket. So you want to keep yourself in a good, healthy balance, exercising, getting good sleep. You know, you just have to keep yourself healthy, because otherwise anything that's bad for your health is bad for your Parkinson's. And then there was another one about amino acid supplements. So the problem with the amino acid supplements and any other supplement is that most of them have not been studied with Parkinson's. So Parkinson's is very, very susceptible to something called the placebo effect. And what that means is not, well, I think I'm going to be better, therefore I'm a little better. It's that if you are expecting to be better, your brain will actually probably crank out some more dopamine to make you better. If I had more time, I could tell you about the studies that have shown that, but they're really interesting. So if somebody in the support group says, you got to try this amino acid supplement, or noni berry juice, or coconut oil is the big thing going around, any of this stuff, and they say, oh, well, my husband got 90% better, and you say, I'm going to try that on my husband, and then your husband's going to get better, most likely. Not 90% probably, but the more expensive it is, the better they'll probably get. No, I mean, really, they've shown that the more significant the intervention, the better people get from the placebo effect. In other words, if you're doing a study of a surgical procedure versus just taking one pill a day, the people who had the hole drilled in their skull, even if it didn't go all the way into the brain to put in the gene or whatever, those people get better to a greater extent than the people that just had the pill. So that's why I say the more expensive, the more trouble it is. If you have to mix it up and go out in the woods with 3 witches and boil, toil, and trouble, and it's more likely to have an effect. So the placebo effect is hugely strong in Parkinson's. So if something has not been studied in a double-blind placebo-controlled study, most of us doctors will say, we don't have any data, which is why I get raked over the coals when I go talk to the support group in Santa Cruz, because I don't tell everybody to smoke medical marijuana, because I don't have any data that it's safe or effective. So that's why we're such stick in the muds about this. If you want to drink the berry juice or whatever, fine, but I cannot tell you that the amino acid supplement or anything is helpful. I can tell you that the coenzyme Q10, we did several studies with it. The latest was at 2,400 milligrams a day, which is a lot, and it did not pan out. The placebo group did not separate from the trial group, and they stopped the study early, so there doesn't seem to be any reason to take big doses of CoQ10. So you'll save a lot of money, and you can spend that money going to the gym or buying really nice fruits and vegetables at the farmer's market, which is probably better for you. And then creatine, that study is still ongoing, because that's a study to see if creatine slows the progression. And creatine is a bodybuilder type supplement. But that study, we kind of got a little bit tricked, because they told us it was a 5-year study, but it turns out they meant 5 years from when the last patient of thousands of patients entered the study. So it looks like we've accidentally signed up to do that study for life. And they aren't doing any interim analysis on that. So we don't know yet anything about how the creatine study is going to come out. But it's good that these things are getting studied finally, because if we don't have data, we really can't recommend it. Don't go get chelated for manganese. We just had somebody here the other day showing evidence that welding actually may be a negative risk factor for Parkinson's, so that the risk of Parkinson's among welders is actually slightly lower than the average, as opposed to being higher, which is what everybody's thought for all these years. So it's why you have to have data. You just don't get anywhere without data. I think I covered most of these. Did I miss anybody's question that you're dying to ask? One more. You want to tell me?
Why is Lexapro your favorite?
Why is Lexapro my favorite? Because A, I'm not a psychiatrist, so I only treat mild Parkinson's depression with anxiety. So if anybody has anything more complicated, like a lifelong history of severe depression or bipolar disease or something like that, I won't touch it. I send them to a psychiatrist. So for the little segment of depression that I manage, that one happens to work really well. And it also treats anxiety. Actually, they've studied it to show that it treats anxiety. And so anxiety is one of those things that keeps people awake at night. And that one just usually fills the niche really well for, not for everybody, but for a lot of people.
You notice
So
the patients getting bruising, easy bruising?
I haven't heard about easy bruising with Lexapro. I mean, most of my patients get easy bruising anyway because they're getting older and their skin is thin. But, I mean, I get easy bruising and I'm not on Lexapro, so maybe I should be. Yes?
Do you know anything about Cymbalta or any contraindication?
Cymbalta, I don't think they have that listed as a contraindication. Cymbalta is sort of a similar drug that's also used for pain control and things. I've had patients on the combination without any problems. The problem I get into is when they start piling up these drugs, like Cymbalta plus Lyrica plus Lexapro. I start those drugs. There's too many of similar drugs, and I start feeling like that ought to be simplified. So I don't use those all together. Yes, sir. The presentation, the rest of the presentation. Do you have until midnight tonight? No. So I think what we probably need to do is schedule something for after the first of the year on the maybe treating the non-motor aspects of Parkinson's, because obviously we don't have enough time today, because you all had a lot of questions about sort of the basic things, and so that it's in the handout, so make notes, so next time you can ask questions about those, but we definitely won't get through that today. Yes, sir?
2.5 tablets of 25 over 100 cinnamon. It's equivalent to 25 or 250?
No.
One tablet?
Oh, yes. 2.5, 25 over 100s equals 125 over 250 in terms of levodopa.
Is it more effective to take one tablet instead of 2.5?
Not necessarily, just easier for most people.
It is easy.
But I can't tell you whether that's better or worse for you.
Because that's how I was switched.
Right. Like I said, I can't tell you what's right for you sitting in the audience. Even if I prescribed it for you, I can't tell you sitting here why that would be better, which one would be better or worse. So, sorry. Yes?
In reference to the levodopa, you said that it probably works better if it's on an empty stomach or wait a half hour before or after eating. Well, if, let's say you give the patient the dosage at 9 in the morning, and so 10, 11, 12, 1, so 1 o'clock is pretty much a normal time to eat lunch, but it's at the same
Right, so you have to work these things out with your doctor as far as what's the optimal schedule.
Is it better to push take the dosage a half hour earlier and then have lunch?
Okay, the question is about the levodopa with the protein, which is, there's just not a one-size-fits-all answer to that, so we can talk about it in the office. There's not I can't tell you what's the best thing for everybody to do. Is there a question over here? Yes?
I'm kind of getting new at this. There's the levodopa routine, and then there's the reduced levodopa with the medications that extend the time of it in your system. Is that a new therapy, or is that just a parallel?
Reduced levodopa?
Yeah, you use the levodopa, but you take something else that extends the time.
Oh, so sometimes you can take a medication that extends the amount of time that the levodopa stays around in the brain, and sometimes that may or may not decrease the amount of levodopa you need. It's different for everybody.
What are those drugs called?
That one of them is called Comtan or entacapone, and then the dopamine agonists tend to last longer from dose to dose. They don't really extend the time that the levodopa is in the system.
Is that just a parallel therapy? Or?
Right, exactly. Yeah, it's parallel therapy. So the only thing that really extends the amount of time levodopa hangs out in the brain is entacapone or Comtan. And that is a drug that we don't use as much as we used to because it's the results on the last study that was done were not as black and white as they thought they would be. So we're not using that as much these days. Sometimes we do, sometimes we don't. So it doesn't work for everybody anyway. So, okay, one more question. Yes?
Should you go off of your medication, how long does it take to get back on a schedule normally?
Should you go off of your levodopa? If you go off your levodopa, first of all, we don't ever recommend stopping any of these drugs suddenly. So if we decide to do a trial to see if somebody really is benefiting from levodopa, we might taper it down slowly over a few weeks. We never stop it suddenly because that can cause some serious side effects. So, and then we usually gradually start them up again with smaller doses over a week or two.
So it would take like a week or two to get back into
Well,
the
it depends on
system?
what you were on. If you were on like 20 drugs, then it might take a month or to,
Right.
and if you're really, somebody's particularly sensitive to side effects, it might take longer than that.
But it takes some time to rebuild.
Generally takes some time to get the levels back up if you stop taking your medication. Okay, well, thank you very much. You've been a great audience. Appreciate it.